Okay. It's my pleasure to introduce Doctors Dario Pyffer and Andrew Smith. Dario is a postdoctoral researcher in the Division of Pain Medicine here at Stanford, where he's using simultaneous brain spinal cord fMRI to study mechanisms of pain processing. His PhD work under Dr. Patrick Freund at the University of Zurich developed and validated methods to assess the amount of spared tissue in traumatic spinal cord injury using sagittal imaging. Dario has recently been awarded a return grant to Switzerland, where he will combine these methods to improve the management of chronic pain and traumatic spinal cord injury. Dr. Andrew Smith is an associate professor and rehabilitation scientist at the University of Colorado, Denver. Andrew's research seeks to improve the assessment and clinical management of individuals with spinal cord injury. Andrew has also pioneered techniques to quantify the extent of spinal cord injury and its impact on motor and sensory function, usually using largely axial imaging, which he uses to understand recovery of lower limb function and bowel and bladder control. Dario and Andrew recently combined their methods as contributors to the Spinal Cord Toolbox's recent SEI-SEG tool with the team at Neuropoly. SEI-SEG automates the assessment of spinal cord injury and traumatic and non-traumatic spinal cord injury. And I feel that SEI-SEG is one of the most important advancements in spinal cord injury imaging research in the last 5 years. And I already know of several groups that are currently employing SEI-SEG in their analysis pipelines. And I'm looking forward to hearing this story from Andrew and Dario.
All right. Thank you, Ken. Yeah, it's a pleasure to talk in front of everyone, and especially I'm honored to do this with Andrew, whom I've started to work with, I think, like 4 or 5 years ago. And that's also how I got in contact with Ken, through Andrew, when we started our collaboration. I'm going to have him lead first, and I'm going to jump in later. Andrew, the stage is yours.
Great. Thank you so much for having me. Again, sorry I couldn't be there in person, but it's been really great to catch all the sessions virtually. And yeah, here we go. So, as we know, spinal cord injury is a catastrophic injury that's really life-altering. And these folks deserve a good outcome prediction, right? So our patients want to know, will we walk again? How well will we function? And the gold standard for outcome prediction as it stands right now is called the International Standards for the Classification of Spinal Cord Injury. So that gives us a neurological level of injury. It gives us how severe the injury might be. Is there any residual motor or sensory function below the level of spinal cord injury? And it's a really great tool. And from there, predictions can be made, right? Will the patient be wheelchair bound? Will the patient be able to regain some sort of walking function and other functional recovery? But as you can imagine, it's assessed by clinicians, which leaves it susceptible to variability. This IMSCI classification doesn't really capture the heterogeneity of the neurological injury that could be seen on imaging. And so there's other limitations to this as well. If a patient has spinal shock, if a patient has long bone fracture, oftentimes this type of examination is contraindicated. And so we're proposing that there is a need for objective quantitative biomarkers to help predict pathways and recovery trajectories after spinal cord injury. We know that we're not just referring to traumatic spinal cord injury here. As you can see in this particular case, there's been a vertebral fracture, there's a signal hyperintensity developing within the spinal cord, and perhaps even blood products suggesting injury. But we can also image signal hyperintensity in folks that have even had a degenerative spinal cord injury over time. In the case of degenerative cervical myelopathy, we could also image the lesion in the context of spinal cord ischemia or stroke to the spinal cord. CT is a good modality as well. It's cheap, it's fast, but it really is limited to the bony structures of the spinal column, and it's really, CT is not really sensitive to spinal soft tissue injuries. Dr. Phalens has published with his group showing that clinical practice guidelines in acute spinal cord injury really suggested that it should be performed prior to surgical intervention to facilitate clinical decision-making, and also perhaps after surgical intervention to observe the lesion, predict neurological outcome. So historically, there have been sagittal sequences, sagittal T2 weighted sequences being more, I guess, emphasized in the literature compared to axial. In the past, axial imaging has proposed limited resolution. We don't really believe that currently, but especially historically, there has not been a lot of axial imaging studies on spinal cord injury. Just back in the day, there's more limited resolution. Fast or turbospin echo T2 weighted sequences are really the workhorse for imaging spinal cord injury. These are quick sequences, only about 4 to 5 minutes. And really, as Dr. Fahling's clinical practice guidelines have alluded to, MRI really is a prerequisite for the clinical implementation, especially in the acute stage of spinal cord injury, which has been proposed historically or written about historically. There have been a few qualitative grades using MRI, and this is adapted from Jason Talbot's work, showing that the Schaefer grades are a nice way to take a look at the overall severity of spinal cord injury. So grade A, as you can see in the upper left, would involve a hyperintensity indicating the lesion plus blood products within the cord, so a hemorrhage. Grade B, there's no hemorrhage present, but the hyperintense lesion is fairly large. Grade C, then you see it's a bit smaller. You can see some integrity of the cord in the anterior and posterior sides traversing the lesion site. And then grade D would be no hyperintensity seen. And similarly, Dr. Talbot and colleagues in 2015 proposed a qualitative grading system using axial imaging. So grade A would be kind of the least severe injury on up to, basic score of 0 would be the least severe injury, all the way up to basic score of 4 would be kind of the most severe injury, with not only a large hyperintense signal kind of spanning the whole axial view of the cord, but also blood products or hemorrhage found within the cord. And so these grades are nice, but mainly qualitative in nature. They have been shown to be predictive of a neurological severity. So in the most severe Schaefer type, you see most patients with spinal cord injury have this thing called Asia Impairment Scale A injuries, which are the most severe. There's no motor or sensory function below the level of injury. And then on over to the other side, with the least severe Schaefer type 4 injuries, you see that even though initially some folks might have been classified as more severe spinal cord injuries, by follow-up, at least 22 of these participants have basically shown no residual neurological deficits. And very similar to the basic scores on the axial view, that they are predictive of kind of future neurological status. With the most severe category in this particular case, all the participants remained Asia A classification, versus the least severe. You see a lot of folks are moving towards the better trajectory. Again, nice qualitative grades using MRI. A bit of a pitfall though, they're graded scales that they don't necessarily provide that sensitive quantitative measures that a lot of folks are looking for. Historically, lesion length has also been proposed and as a good predictor of future neurological function. So just how long kind of cranial caudally does this hyperintense signal span? And you can also see the indication of hemorrhage is typically associated with a motor and sensory complete injury. Other quantitative measures have been shown, some ratios of how much is the actual spinal cord compressed after SCI, and this is prior to surgical intervention. And then also how much is the actual spinal canal compressed, and there's some ratios that you can work with here. All three measures show prognostic value, and especially lesion length has been shown promise for outcome prediction. And Dr. Phelan has really pushed for that early neurological decompression from a surgical side to help alleviate the compression on the spinal cord itself, and then also earlier decompression leads to better outcomes typically. However, so far in the literature, most centers and studies have focused on this acute stage of spinal cord injury when MRI is typically performed, again, in order to guide surgical intervention. But you can see in this figure, there's this widespread edema within the first 48 hours after spinal cord injury, as opposed to if you wait about 3 weeks after the injury date, you see that this nice cystic cavity has been formed, creating this hyperintense signal within the spinal cord. And you can see these, the integrity of the spinal cord, both anteriorly and posteriorly. And Dario and Patrick's group have coined this term tissue bridges, mid-sagittal tissue bridges that you can see here, beginning to form or emerge, I should say. And by the chronic phase, this lesion has stabilized, and you can see that those spare tissue bridges mid-sagittally are still present. And I guess my soapbox is that, again, most of these folks, if they receive an image, they only receive it during the acute stage. There's really only a few groups of us that care about this subacute stage. And I guess my soapbox is, you know, if you, let's say, God forbid, one has a cancerous tumor, you're going to have this serial imaging occurring, right, in order to track the lesion severity and the lesion changes over time. We know that this happens in spinal cord injury, and yet most centers don't even bother to get that subacute image at that 3-week time point, which Dario will talk about next. And we do believe that that's very important for prognosis and clinical trajectories. So I will mute myself, and Dr. Pyffer will continue.
Is it what is perfect? Great. Yes, you can hear me. Wonderful. Thank you, Andrew. That was a perfect lead, and I'm gonna get it from there. I want to show you why we think this is so important to get the lesion image at the subacute stage when it is less dynamic, because in the first few days it really depends if you image the subject at like 3 days after the injury or 4 or 5 days after the injury. There's so many changes in the acute phase, and we want to show you how relevant it is to do that at 3 to 4 weeks when the widespread edema has mostly resolved and we can see the actual tissue damage. So in one of our studies in 25 paraplegic patients, we, as Andrew mentioned before, we have come up with, developed and heavily applied this lesion segmentation model, where we previously manually segmented the lesion to get, on the mid-sagittal slice, to get measures of lesion area, lesion length, lesion width, and then also these the spare neural tissue adjacent to the lesion on the ventral and on the dorsal side. At 3 to 4 weeks, as we've mentioned before. And as shown on one of the first few slides, we can see that we can detect such a lesion in traumatic SCI as well as ischemic SCI. So in this study, we looked at both of these etiologies, as you can see here, and show that these are actually relevant for recovery. So we looked at the correlation between the lesion measures at 3 to 4 weeks and the clinical outcomes at 1 year. And you can see here that the lesion area, for example, is negatively correlated with the lower extremity motor score. So LEMS is lower extremity motor score, and then the pinprick score. So basically the clinical test examining or testing spinothalamic tract function, where they have to distinguish a needle from more dull sensation. And then similarly, we have shown that there is a positive correlation between the mid-sagittal tissue bridge width and the lower extremity motor score and the pinprick score at 1 year after the injury. So here you can see that in patients with an incomplete lesion, we can usually detect these tissue bridges, as seen in the top panel, whereas in patients with a complete lesion, so AAS grade A, we do not see any spare tissue on the mid-sagittal slice usually. Interestingly, those with an incomplete lesion, they can have vastly different clinical pictures and rates of recovery. And this is what we sometimes refer to neuroanatomical functional paradox. Why is this? It depends on which sensorimotor tracts are affected, as you could imagine. So, for example, here we have someone with a good recovery of light touch, and here's someone with bad recovery of light touch. You can see that the lesion is not exactly located at the same place. And when you have an axial view of the spinal cord in mind and where the tracts are running, you can see that this actually makes sense. So we really can gain some more valuable information from referring to either ventral or dorsal tissue bridges to get an estimate of which tracts are spared. So in a second study in 70 patients, including both patients with a cervical injury and thoracic injury, we looked at the prognostic value of ventral and dorsal tissue bridges for recovery after the injury. And you can see here, first of all, that both ventral and dorsal tissue bridges were highly predictive of AS grade conversion over the first year after the injury. So again, the AS grade conversion, as Dr. Smith mentioned before, is determining the severity of the lesion, and we would expect that those with a smaller lesion and more tissue spared are actually converting to a better AS grade. And this is what we saw here, so some predictive value of the spared tissue. And then also we can correlate that, so the actual width of the tissue bridges to the normalized rate of AS grade conversion. And we use the normalized rate here because you can imagine someone with an AS grade D, so not really a severe injury. They have wider tissue bridges, but of course they're not likely to improve in AS grades because they're already at like the lowest severity before changing to actually no neurological deficit at all. Just want to highlight again here that these are really meaningful. We can use the width of spare tissue to prognosticate if someone will recover, so convert on the AS grade scale. For the second part of that paper, I want to quickly introduce a data-driven approach that we used, which is prediction-based decision trees. So you can imagine here how that works is from a set of predictors in a heterogeneous patient population. We want to identify the significant ones and their corresponding cutoffs. And this is done by an algorithm. As I said, it's a data-driven approach. And these cutoffs are identified to maximize the difference in the resulting subgroups in the end with regard to a clinical endpoint. For example, upper extremity motor score at 1 year, or also pinprick score at 1 year. This will help us to identify these recovery-specific subgroups, which is important for implementation of targeted care, and also when you think of how you want to plan future interventional trials in SCI. So you can see here that this is one figure of that paper. We had a different, like a set of predictors, which includes, for example, the baseline pinprick score, which of course is heavily correlated to the 1 year pinprick score. If you start with a higher pinprick score, they're naturally going to end up with a higher pinprick score as well, because the lesion is smaller. But we wanted to see if like neuroimaging measures add prognostic value to those baseline clinical scores. And we can see here that after a first split with baseline pinprick score as a predictor, our baseline ventral tissue bridges here show up, are identified by the algorithm, with a cutoff of 1.4 millimeters, splitting that subgroup of 51 patients into a subgroup that ends up with a lower pinprick score at 1 year, and then one with a higher pinprick score at 1 year. And these 24 patients that are showing better recovery are again split up here into two more homogeneous subgroups because the algorithm identified pinprick score with another cutoff of 75 here. So this is encouraging because the ventral tissue bridges are thought to be like a proxy for some of the more ventrally located tracts, including the spinothalamic tract. And then this is some work here by Dr. Smith and also Dr. Weber. Because we're talking about which tracts might be affected, you naturally want to use tract-based analysis, right? And so you can quantify the lesion and then see how certain tracts might be affected when projecting that to the axial plane. And I will talk more about that later, but just here I want to show you some of those first pioneering results that show that the percentage of spared corticospinal tract and also dorsal column tract, they can predict your recovery of motor score and also sensory scores respectively. And this again shows that you can see that the right and left lateral corticospinal tract spared tissue is different. So there's a difference in that spared tissue between AS grade converters and non-converters. So those with more spared tissue are the ones that are likely to convert on that AS grade scale. So gets better over time. So as a summary, we can say here that the lateral corticospinal tract and also dorsal column damage predict motor and sensory outcomes at hospital discharge. I'm curious whether you've seen these pictures before in our presentation. You might have, if you paid attention, saw some of the artifacts that we often see in spinal cord injury patients, which are those here. And these are actually from metal implants. Because there's most of the patients, not only the traumatic patients, but also those with degenerative cervical myelopathy, they undergo decompressive surgery, and so they will have metal right next to their spinal cord from like the earliest day on usually. So I want to talk a bit about these metal implants, how they could be a pitfall in our research and what we can do to maybe avoid that or improve that. So signal dropout, as you can imagine, can obscure the focal lesion. This is like an extreme example, but often seen, especially for thoracic lesions, where you usually have more or more severe bone fractures, and you also need more metal to stabilize the column. So you can see that the focal lesion is obscured. In fact, like half of the cord is just blackened out on this T2 weighted image, actually, what is funny here, so scanning at lower field strength can be beneficial, as you can see on the right side for a 1.5 Tesla scanner. And we have shown in some of our papers that we can accurately and reliably quantify the lesion on both magnetic field strength, so this is good for generalizability. But we want actually better methods to avoid these metal artifacts than just scanning at lower field strength. So there's been some work done by other groups to reduce metal artifact induced or to correct for those metal artifacts, some of which are described here. So one of them is the CEMAC VAT, so view angle tilting. As you can see here, it's definitely helping reducing some of these distortions from the metal artifacts, which in this example, it's not in SCI, but it allowed them to detect some fluid accumulation next to the spinal cord. So these are some of the technical developments. Here's another one, as you can see here, using warp. This is on the axial plane, and on the left side you can see that you do not really see the cord at all because of the metal screws and implants, and on the right side, using the warp T2 term sequence, you can actually see the spinal cord. So just have that in mind if you have to scan someone with hardware, there is solutions to mitigate these artifacts. To come back to our goal of identifying neuroimaging biomarkers in SCI, there has been some work done, and it has been acknowledged by the community that these biomarkers identified using conventional MRI with usually rapid acquisition, that these have the potential to serve as neuroimaging biomarkers and not just being used in clinics for surgical decision making. The thing is that we need to show that they're reproducible and also that they're generalizable across multiple centers. And this has yet to be demonstrated. And that was about a year, 2-3 years ago when we acknowledged that and wanted to change that. So we started a multi-center project, as you can see here, with Dr. Weber, Dr. Smith, and then also Dr. Freund, who's my previous PhD supervisor, using these 3 centers in Switzerland, Germany, and the US. There's a lot of detail, but I want to highlight that we included 227 cervical SCI patients across the 3 centers and followed them up to 1 year, looked at their outcomes at 3 months and 12 months to get information on short-term recovery, but also long-term recovery. And the outcome measures we included are the usual suspects, so sensory scores, pinprick and light touch, and motor scores assessed via the INSCI neurologic exam that Dr. Smith mentioned in the beginning. And the conventional imaging was done at 3 to 4 weeks, post-SCI again as early as possible, but also after these first 2 to 3 weeks where we see dynamic changes still. Exactly, and 3 months was also a crucial time point because this is usually the average time that someone leaves their rehabilitation in the hospital. There's usually some rehabilitation programs for the first 3 months, and then they leave the hospital. So we want to get an estimate of how much they recover in the hospital and also for the next 9 months. These are just some representative images from the 3 centers where you can see incomplete lesions, so some patients with incomplete lesions and some of the spare tissue adjacent to the lesion. Important, as I said before, there were only very few dropouts because of metal artifacts, luckily, and we can very precisely, accurately segment the lesion. At that time, still manually, which is different now that you will see in a couple slides. So at that time, still manually, we manually segmented these lesions, so by trained raters, and showed actually very, very nice ICC. So this is reliable across raters and also within rater. And it's irrespective of scanner, vendor, and model, and also field strength. So these were images from 1.5 Tesla, 3 Tesla, different manufacturers. Here, before showing you the first figure of that paper, I want to show you a model that has been proposed by Fuad and Schwab, which shows that there's actually a nonlinear relationship between the lesion size and the amount of recovery. So there's a sweet spot, as you can see there, like a window of opportunity. So because if you have huge lesions, you don't expect any recovery. But then for smaller lesions, you soon see a very steep recovery that gets flattened out if you have no lesion. And we now imagine this being swapped because we're not talking about the lesion size per se here, but the number, the amount of spare tissue. So I want to keep this in mind that we would that we hypothesize to see something similar to that when looking at tissue bridges and the amount of recovery. So we would imagine on the x-axis the amount of spare tissue, and on the y-axis the percentage recovery over time. So we actually use nonlinear models, logistic models, to look at that. And you can see on the x-axis that this is, so from our data, the width of spare tissue. So 9 to 10 is about the spinal cord diameter from ventral to dorsal side. And you can see that they are, there's a nonlinear trend with regard to the recovery in all of these outcomes, pinprick in red, light touch in green, which is mostly testing dorsal column function, and then motor score in blue. These were scaled. Again, these were normalized and scaled because if someone starts with already a high motor score, they will not improve much. And this will not really, this would induce a bias because of course these have like usually smaller lesions, a high amount of spare tissue, but they wouldn't show lots of recovery. So this is why we normalize the recovery rate and then scale them to actually run the logistic regression. And these models importantly are adjusted for age, sex, and center, and also the injury level. And with that, you can basically come up with an estimate of the score that someone would improve per millimeter of tissue bridges they have spared. So here you can see if someone has like 4 millimeters of tissue bridges spared, you just multiply that number by 4 and you would see how much someone would be expected to gain over the first 3 months. And then it looked very similar for 12 months, as you can see here, but due to the sake of time, I'm not going into detail here for 12 months. And as like an interim summary with regard to tissue bridges that we have worked on a lot is that we can say these are predictive of both short and long-term recovery after SCI. They can stratify patients using these decision trees into more homogeneous subgroups. They have the potential to improve outcome prediction, clinical decision making, and personalized medicine. And we have identified this like kind of window of opportunity for bigger lesions, so a little bit less tissue spared. But we have seen that many patients that have some tissue spared, even if it's just a tiny bit, that they actually show some good recovery. And when you think back of the decision tree, the cutoff that we identified, distinguishing these subgroups was actually quite small. It was like 1.4 millimeters with regard to the pinprick outcome. So if we think further, what we would like to see in the future is these serving as targets of neuroprotective and neuroregenerative agents, and looking at how these change tissue bridges upon intervention. So they prove crucial for external validation, which we also did in our multi-center study, which I'm not including here, but please read up on that. We externally validated all of these findings and decision trees, which is again very important for generalizability of the findings. And we demonstrate the global clinical applicability of it. And we really highly advocate for implementing these in clinical care standards and tried to push this. I know from my previous mentor in Zurich, there's already an imaging report that is being integrated in clinics, actually. Also now with the help of Jan Walsek, who's working with the Zurich team now. So using that imaging report, you can have a better picture of how the patient presents compared to the more subjective clinical outcomes. But then it's always the question, if you want to try and have something implemented in clinics, it's usually slow. It's mostly not going to happen because it might take time. It's complicated, so you have to overcome some barriers. And the time aspect we try to tackle with our collaboration with the Montreal team led by Julien. But first, before coming to that, I'd like to show you that in another study where they used spinal cord stimulation transcutaneously, we have shown that, so here in a study by Andrew, we have shown that tissue bridges can actually distinguish responders from non-responders. So this was like a secondary analysis that was done after the interventional trial, like a big interventional trial. And then Andrew looked at these secondary analysis, and he was interested in how responders actually differ from non-responders to the intervention, to the spinal cord stimulation, and has seen that those that respond are actually those with spare tissue compared to those that do not respond to the intervention. Now I want to get back to how we can actually achieve implementation to clinic. So I mentioned that we have previously always manually segmented these lesions. It takes expertise and it takes time. So here in our collaboration with Jan and Julien, we have worked on an algorithm that automatically segments the spinal cord lesion in three-dimensionally. Using a deep learning algorithm. So you had like many images from different centers with the ground truth, with the manual segmentation. So the algorithm was trained to detect these lesions on T2 weighted images. So you can see here that these images probably look, or some of these images look familiar to you from the past 2.5 days. So actually the spinal cord is first segmented, and then the hyperintense area, the lesion, is segmented as well. In a second step, here indicated in blue, and based on a lesion soft mask, we can actually get estimates of the lesion volume, the lesion length, also on the mid-sagittal slice, the lesion width and length, and also the amount of spare tissue on the mid-sagittal slice. So this is an AI-based software solution, and especially now with the generic acquisition protocol, where we get the T2 weighted image with isotropic voxels, we can also, or we want to look at the axial slice as well, because this will prove especially useful when we think about tract-based analysis. So you can actually overlay the lesion on those white matter tracts and get estimates of, here, I'm not sure if you can see it, but in the table, you actually get like automatic outputs from Spinal Cord Toolbox on how much of certain tracts are damaged. So this will be super useful, and again, the 3D T2 weighted sequence allows us to do that lesion morphometry analysis on sagittal and axial slices. And again, it's super quick. It doesn't take much, just a few lines of code, and then you get the information on the lesion volume, lesion morphometrics, and also by how much certain white matter tracts are damaged. A few more details on the algorithm. It has been trained on different time points. I think, as we have quickly, as someone mentioned during the workshop before, it has been trained on DCM etiology and also traumatic SCI, so it can reliably detect all of these hyperintense signals and quantify it in different, in non-traumatic and traumatic SCI. It's very easy, 2 lines of code. I'm gonna leave up that for a second. It has been implemented in Spinal Cord Toolbox version 6.5 and is available from then on. So it's openly available, and again, very quick and reliable. We have also, in collaboration with our colleagues from the University of Oklahoma, we have looked at that in non-traumatic SCI, so degenerative cervical myelopathy, and have shown that those with more severe DCM are actually the ones that have bigger lesions. This correlates with balance and dexterity outcomes, and similar to tissue bridge as well. And we have now, this is on medRxiv available, and we have now an updated paper with some tract-based analysis just submitted. In the last 2-3 minutes, I want to talk more about secondary degeneration, which is very, very pronounced, as Gerge has mentioned before. So we can see here in that figure that I created, there's like a focal lesion in the cord there, indicated by the red area. But we have shown, and mostly Dr. Freund's team with Gerge and others from my PhD team, we have shown that in many different studies using different kinds of MRI modalities, that there is neurodegenerative changes after SCI in the cervical spinal cord above the lesion, in the lumbar spinal cord below the lesion, in the brainstem, and also in really widespread in the brain. The only small pitfall here is that DTI and T2 star weighted MRI at the lesion level is tricky due to metal artifacts, but they also wouldn't really add a lot of valuable information. So it's we're making use of these modalities to look at changes above and below the lesion. So here in some of Gerge's work in SCI using DTI, he compared changes in DCM and traumatic spinal cord injury, also looked at diffusion metrics specific to certain white matter tracts. And he showed that there's pronounced changes in the spinal cord area, quantified by those T2 star weighted images, also in the white matter and gray matter, also measured on these images assessed via the Megra sequence, and then also both above and below the lesion, so at C2, C3, which is above the lesion here, and also, or above and below the compression in case of DCM, and then also in the lumbosacral enlargement below that level. Here, very similar, there's pronounced differences between healthy controls and both DCM and traumatic SCI with regard to the fractional anisotropy in different white matter tracts. And because this is a lot, Gerge has actually put together this nice visual summary that you can find in the paper that I referenced there, where you can see above and below the lesion or the compression, what degenerative changes we can see with regard to macrostructure, so from T2 star weighted imaging, and also microstructure from DTI. And actually, as I've shown before on the image, these changes really extend to the brain. We have many other studies that I can't cover now, which show changes along the motor system in corticospinal tract, and also in M1 in the primary motor cortex after spinal cord injury. But this is beyond the scope of this workshop. And with that, I'd like to end. Thanks all the collaborators, many more that I couldn't fit on this slide, and we're open for questions, I think.
Great job, Dario, and thank you, Andrew. Any questions from the group?
Thank you so much for an amazing talk. I'm still slightly new to the field, and I was really I had some clarifying questions about your lesion analysis. Does signal intensity tell us anything? Question one. Question two, when you said lesion size percentage, what is the percentage with respect to, like, is it the whole spinal cord? And sorry, question three. When you calculate the bridges, like you decide where to draw the bridges, are they at the biggest point of the lesion, so they're the smallest value you can find, or the average across the length of the lesion? Thank you. Sorry about the many questions.
Of course. Can you say the first one again? What about the hyper?
Yeah, the signal intensity. Does that tell you anything with recovery or between subjects? Because I guess in the knee, if you have a cystic bone marrow edema, it's very different from a diffuse bone marrow edema. So, and you're more likely to recover from one versus the other. So I don't know if you've looked at signal intensity, because you already have segmentations.
Yeah. Oh, there's some early work they have looked at signal intensity differences, but it didn't seem to be like very promising. It was like the major point is whether there is actually, so in this, the cyst is basically just filled by CSF, and we wouldn't expect like lots of signal intensity differences. And I think people looked at it, and it didn't matter like how intense that is. Just if you see like hypointensity, so in the early days when you have hemorrhage, or hyperintensity building up after. Then the second question was about the tract damage with regard to what? This is basically the size of the tract on the axial view, and based on this would like refer to 100% of tract sparing, right? And then if you calculate, then if you overlay the lesion, then you can see the percentage of that tract damage. Of course, you can also do it with regard to the whole spinal cord. But basically anything you want, you can also do it according to the white matter, to the gray matter, or certain tracts. And then the third one is the tissue bridges. That's a very good question. So we started developing that model on the mid-sagittal plane. And then when you imagine the lesion on the mid-sagittal plane, then you look at the narrowest point of neural tissue being spared inferior posteriorly. Exactly, because this is like the shortest we would expect, even if you might see a little bit more, or above or below, you might see more spare tissue. At some point, it's still affected by the lesion, right? Like the maximum width of the lesion. This is basically where we measure the spinal cord tissue bridges.
It's really interesting. I wonder if the spectrum is actually interesting on its own as well. Like, why are some people having more like ellipsoid lesions versus maybe more diffuse?
Yeah. There's many interesting avenues to go. Also, people looked at some parts of like the lower lesion, because there's this concept of like zone of partial preservation. You can look at basically also some spare tissue on the lower end and then see how these specific segments at that spinal cord level, how the recovery of these like individual segments is. Yeah.
Thank you so much.
Mm-hmm.
Questions?
Nice presentation, Andrew and Dario. So I fully agree that we should move to axial slices because we can do tract-specific analysis, something which is not possible on sagittal images. And I'm wondering that you showed the study where you looked at, I think, and it's your study, Andrew's study, that you looked at tract-specific damage, and the y-axis was maybe if you can go back.
Yeah, I will go back. Yeah, this was Andrews and Ken's work.
Yeah, the improvement. And there is clearly a correlation, but the explained variance is not that high. So there is still something which we are not capturing, right? Yeah, exactly that one. So you can have a similar tract damage, but different improvement.
You
right?
mean
So,
like with regard to the scatter plots, right?
Exactly. So what do you think? What's the aspect that we are not getting yet? Or what
my
can
quick answer?
Yeah.
Oh, sorry. My quick answer to that would be not all of these images had that nice scan that we're suggesting for the generic spinal cord protocol. So not all of them had that beautiful kind of isotropic 3D T2 high resolution image. So we just kind of used what we could get because this is a retrospective study. We're hoping that we can kind of in the future reproduce these findings in a more prospective fashion. And again, the resolution of left corticospinal tract estimates, it's really an estimate at this stage, compared to clinical lower extremity muscle measures, you're going to lose some resolution there. It's just a subjective scale, 0 to 5 for each key muscle group. Whereas, and actually a previous study that Ken and I did used plantar flexion torque and knee extension torque, and we found a little bit tighter relationships. So I would say, obviously imaging isn't going to account for everything, but I think the relationships could get stronger with better imaging and better quantitative measures of output.
So a follow-up question on the acquisition side. So you mentioned that 3D isotropic images might help, but then we lose resolution in the axial plane, right? And the axial plane is arguably the most important for tract-based analysis. So what are your thoughts? Should we use an anisotropic resolution with high in-plane resolution and sacrifice resolution along the slices, or use isotropic resolution?
I personally would like to see both. Another thing, if I remember this particular study well enough, is that because it was retrospective data, there's a lot of gaps between slices as well. And I think that if we could even tighten it up so there's no gaps, that could probably improve of the overall analysis as well.
One axial plane.
Yeah. Yeah, exactly. But if it's a 2D acquisition, then typically we have like 0.4 or so in plane.
Okay. Well, I guess you should go higher res with 3D. So the image on the left is a different study versus the image on the right. The image on the left is with high resolution isotropic imaging. The image on the right is clinical imaging that sticks axial slices from the hospital.
Yeah.
Yeah. So just.
But I agree that would be good to compare, having an isotropic voxels using that sequence and see if you can still reliably assess like the measures we want on both axial and sagittal planes and then compare. Yeah, that might be worth it.
But I would think 3D isotropic imaging would be better than 2D. If you want to accurately quantify the whole body, just go higher res, I think, with the 3D imaging.
Yeah. Yeah.
Thanks for the very nice presentation. I was wondering about the tissue bridges. I know at first you did them on mid-sagittal slices just because of mainly the images. But now that you have 3D images, is there a use to not compute them, like as ventral and dorsal, maybe some lateral tracts or other? Yeah, what do you think about that?
Yeah, I think so too. This is stuff we're gonna explore now, with everything being automated in Spinal Cord Toolbox. So it would be very, very nice to see more of like maybe like portions of the white matter being spared. Your lateral and ventral and dorsal parts maybe compared to as just on the mid-sagittal slice, because this, even though we have shown in many studies that is prognostic of recovery, it's still like very limited, like a small like thing that we're looking at, and definitely not the full picture. And also one of the reasons why we sometimes didn't detect the recovery that could be seen. If someone has no spare tissue on the mid-sagittal slice, it doesn't mean that they're like having a complete lesion, right? So it could really be that we miss some of this spare tissue, and those also cannot account for the recovery that is observed. So looking at more other parts of the white matter more broadly that is spared, this is definitely something we want to do now. Mm-hmm.
Thanks.
Thank you for the talk. So I had two questions. One was, you had mentioned the SEMAC-FAT and the T2 term sequences as alternatives to get less susceptibility. So could you tell us a bit more about the acquisition for those images? And second question was, have you tried looking at tissue bridges in acute SCI? And have you found anything relevant in there?
First question, a lot of these studies have been assessed retrospectively. So again, imaging is not really performed, or is not performed in many SCI patients. So we had to rely on data that was available from different centers. And they're usually not using these more advanced sequences yet. So I don't know about the exact parameter. I would also need to look these up, and also if they maybe need more, use more time to get the images acquired. And then secondly, what was that question?
Second was about just in acute.
In acute.
Spinal cord,
Yeah, exactly. We have that one study where we looked at changes of lesion morphometrics at the acute stage. I can show you which paper I'm talking about, but this is by Dr. Emmenecker, who was a PhD student in the group as well, where we looked at the hyperacute stage, basically, some of the lesion measures there. You don't really see spare tissue, even though it's there, because there's a lot of edema. So we mostly focused on the extent of the edema, but also some of the spare tissue that you can see, and then how these changes within the first few weeks, and which is very interesting. Actually, the rate of change during these first few days was predictive of motor recovery along the whole motor system. There is some information, useful information on the dynamics of the edema changes, let's say, in the first few days or weeks. But we really have mostly used it on subacute images.
Thank you.
So thanks very much for your talk. This is maybe just too broad of a question, but I guess in your experience and with some of this research, did you ever get pushback on the use of these, especially with your window of opportunity? I don't know if this is a modifiable factor that we can change in any way. So did you ever get pushback on oh, it's great, maybe biologically we understand that this compression is causing this to be the case, but I don't know, surgically they're still going to do the same intervention that they would do to try to help the patient in whatever way that they can. And then in terms of a rehab perspective, Andrew, you would know a lot more about this than I do, but do we know of any interventions along that course that changes this in any way? Just curious what your thoughts are.
Yeah, I think we're not there yet. And please, Andrew, jump in if you want. But I don't think we're there yet that people really use them in clinics to guide rehabilitation or anything. It's mostly, if MRI is being consulted, then early on for surgical decision making. They look at like the fractures, right? But then also maybe the amount of edema and hemorrhage as well, to see how severely affected they are. I'd love to be tissue bridges to be consulted at some point for clinical decision making. Probably not surgery. It's just too late at 2 to 3 weeks. But for like more precise rehabilitation decision making, maybe. And I'm also think in humans, unfortunately, this is like very macrostructural. Like these measures are very macrostructural. With regard to your second question, I do not think they will or not, or maybe with like better resolution. But right now, I do not think we can expect significant changes after an intervention. You know, I don't think these will serve as like correlates of to test if an intervention was successful or not. I wouldn't expect like the width to change necessarily in humans. This has been shown in animal studies in rats that you can actually have like wider tissue again after intervention. Not in humans, because we're just not that. The repair system is just not like that well developed in humans. But it's like great to actually plan clinical trials. You know, it's been used now in the most